How are you?
Hey, how's it going? Good to see you.
Yeah.
Happy
Happy
New Year.
time.
So, I think primarily what we want to do today is just go over your OncoDX results
Okay.
and kind of put them into perspective. Just to sort of recap, we're talking about the prostate cancer diagnosis. You have a relatively low risk appearing situation. You have a relatively low PSA. You have 3 positive biopsies, only one of which contained any medium grade or intermediate grade disease, and that was only a very small proportion of the biopsy. So you had 5% of that Gleason pattern 4 stuff. So we were kind of in this position of trying to think about decision making in terms of surveillance versus intervention. There's no absolute right answer. So we did the genetic testing to kind of look at that. And it's kind of interesting. I mean, the genetic testing is sort of in the middle of the road in terms of what it's telling us. And I think the way to look at that is that the genetic testing, we're using it like we anticipate it's kind of a crystal ball, right? What the potential of this is over time. It's not really telling you what's going on right now, right? It's more about, where is this going to go in the long run? And really, it's kind of right in the middle. And what does that mean? Well, if you look at the numbers, as expected, it shows a very low risk of either developing spread of prostate cancer or dying of prostate cancer, within a decade. Okay, that's not surprising based on your biopsies. Those are all very low risk. The other thing that what this does is it tries to predict the chance of having more adverse pathology if you were to have surgery. So in other words, if you had your prostate taken out, would we find higher grade disease, meaning that there would be a lot more of the type 4 variant or worse? And would there be evidence of locally advanced disease or disease outside the prostate? Now, I will say that I find this aspect of the genetic testing helpful, but also it's a little misleading because, again, I think about the genetic testing more in terms of the potential of this disease to subsequently cause problems in the future. Not so much about if we took you to surgery tomorrow, what would we find? I think that, what the numbers show is about a 30% risk of having higher grade disease at the prostatectomy and about a 30% risk of having T3 disease or higher, meaning that disease that's kind of grown through the wall of the prostate. But keep in mind that those numbers are they're low, relatively low, but they're also the risk of T3 disease has a lot more to do with the morphology of the prostate cancer that we're seeing on MRI than it does with genetic testing. So I would say that the risk that these numbers show us is more about what could happen in the future if untreated, more than it says what's going to happen now. So I will say that when we do the genetic testing, it's always a little bit challenging, just like anything, when you have something that's right in the middle of the scale of risk, right? If you get a genetic test back and it shows extremely low risk, then it reinforces our interest in doing surveillance. And if it shows very high risk for some reason, then it tends to push us towards intervention. But when it's right in the middle, you're kind of stuck because you could flip a coin essentially. So I'm not sure what to really do with this information. I would say that it is not super low risk, but also not super high risk. You absolutely could consider just continuing with your strategy of active surveillance, understanding that, within a year, we should probably be repeating your imaging and repeating a biopsy to get, more up-to-date information. I think that the genetic testing is perhaps suggestive that if you looked out over many years, the likelihood of this subsequently needing treatment at some point is probably higher than average. And that's probably the take-home message from this, rather than, but that's not to say that it's 100%. What it doesn't tell us is that, right now, this second, there's something worse going on than we think. I really don't think that's what, you can't really use the genetic testing to say that. That interpretation is based on the other parts of the workup, the PSA, the MRI information, the biopsy information. Those are telling you where you are right now. This is more about, where are you going to be in a few years? And, I would, as I said before, I would say this probably suggests that the need for you to subsequently be treated at some point in the future is probably a little higher than average.
Okay.
Does that make sense?
Yeah. So can I recap to make sure I understood everything? So basically, based from our tests, we don't have an immediate danger likely right now, but there's
No.
medium risk that it's fairly likely that we will need intervention sometime in the future. And if we do active surveillance right now, it's basically not doing anything except for in a year we'll do the biopsy and imagery again, and then if that's okay, we just keep doing PSA tests until otherwise
Yep.
indicated.
Yeah, and I think the way to think about it, one other way to think about it is when you look at active surveillance, you could be asking two questions, right? One question would be, if I do active surveillance right now, am I missing something bad that's going to hurt me right now? And I don't think there's any reason to suspect that based on this. The other question that you could ask is you could say, well, if I'm doing active surveillance right now, I know that somewhere between 30 and 50% of people on active surveillance ultimately need to get treated, right? So what I'm essentially doing is deferring my treatment until later. And this testing perhaps nudges you a little more towards thinking that eventually you're going to need some kind of treatment. So if you're going into active surveillance thinking that, okay, this is a great option for me because I don't think I'm ever going to need to be treated, perhaps these results make that a little less likely. Okay. Now, the data that's out there very strongly says that if you go on active surveillance, it's unlikely that that is going to alter your subsequent outcome. Right? It doesn't put you at risk for bad outcomes very much. It's a very small risk. So again, there are some patients, for example, that have been in my practice, for example, that have been on active surveillance for 8 to 10 years. Okay, and then ultimately at the end of that process, we subsequently treat them. And we discover that, at the time of surgery, they have a little more adverse disease, but that doesn't mean they're not curable or treatable, right? So I think that, on the other hand, some people, maybe half the people on active surveillance, just never end up getting treated because they never really manifest anything that is more dangerous. So I think what I like to think about the genetic testing is telling us, this is perhaps more significant in the long term, measured in terms of a decade, than the average person with low volume, low grade disease on biopsy. That's all.
Okay. Yeah. I think that makes a lot of sense. I appreciate your explanation.
So if you ask me what I would do in this situation, again, I can't tell you what to do because everybody's going to have a different risk, profile and what they're willing to do and how they want to run their life. I would be comfortable with surveillance here, but I would want to make sure that you were comfortable with the idea that, we have to take it kind of seriously because we probably can't just ignore this. It's unlikely that it's completely clinically irrelevant. And that it is possible that we would be having a conversation in a year after a repeat biopsy that, we would be more inclined to treat you at that point.
Yeah.
However, there's no guarantee of that, but I think it's a little more likely than not based on the genetic testing. Again, the genetic testing, you should keep in mind that mostly what we're looking at on that is the Gleason 4 variant, right, which is a very small proportion of what you have. And so, that particular variant might have some more aggressive potential behavior. And but there's very little of it right now, at least as far as we can tell.
So I guess next steps would be, we're kind of at a crossroads is how I see it. We can decide whether we'll probably have to discuss. We'll decide whether we want to continue active surveillance, which would be with you, I guess, right?
So if you can do active surveillance, I would repeat your PSA in about 6 months, and then we would plan on repeating an MRI and a PSA in a year with the likelihood of getting another biopsy at that time.
Okay. Plus PSA 12 months. Sorry, I'm writing all the notes down. I'm a big note
Yeah,
taker.
that's good.
Yeah. With likely biopsy. Okay.
Yeah, I think that for anyone on active surveillance, it's generally considered essential to rebiopsy them at some point, probably 12 to 18 months from their initial biopsy.
Okay.
I would be inclined with this genetic testing to be a little bit earlier in that process and maybe do it at a year.
Okay. That sounds good. And then, so if we don't want active surveillance, what we would do is basically go jump into treatment, which is either radiation or surgery.
Yeah, and again, I think that you could go either way, but I would probably be more leaning towards surgical treatment.
Mhm.
Yeah.
But again, you could go either way at age 68. I think
Yeah.
that in general, with younger, healthier folks, we tend to be a little bit more inclined to do surgery just because
Okay.
we want to have options later should we
Mhm.
need them. 10 years from now, if we need to treat you for a local recurrence or some other,
Mhm.
having the radiation as an option at that point would be better. But again, that the decision really first off is treat now or surveillance. And then,
Right.
if you decide, okay, look, I'm just not comfortable with the risk profile, which I actually wouldn't recommend, but if you decided that, then we would go dig more into the treatment of options in those two.
Okay. No, I think I know we understand where to go next. I think we're just going to talk about whether he wants to do the treatment or surveillance. I think he's leaning
Yeah.
towards treatment, and if we do treatment, which radiation, which one?
Yeah,
Yeah.
exactly.
Yeah.
That's fine. And we can always have another chat if you have questions specifically about, some of the things that we talked about previously in terms of the radiation versus surgery option. But
Yeah.
basically, they both have their pluses and their minuses in terms
Yeah.
of, recovery and subsequent management. Nothing is as, free of trouble as surveillance, right?
Of course, yeah. But he doesn't
but
really
again,
want to do the biopsy. He's like, the biopsy
Yeah.
was miserable. He's like, I don't want
Well,
to do
and
that.
some people, honestly, some people opt to go down the treatment option just
Yeah.
because they just don't want to have repeat biopsies.
I
And
know.
Yeah, that's
You know,
where
that's
he's
okay.
leaning, actually.
yeah, that's fine. Just let me know if you want to have another chat, or if you decide,
Yeah.
if you want to,
Things-
if you decide you want to do surgery, then we can certainly start looking at options for doing that. Again, this is a situation where I would probably do this as a single port procedure. Usually, that's an outpatient surgery, not a.
Okay.
Don't have to stay in the hospital. We don't go into your abdomen to do that surgery. And usually after that surgery, you have a catheter that stays in for about 5 days or so, and then it comes out. So again, the surgery has gotten less involved in terms of recovery, but it's still surgery and
Yeah.
not trivial. But I would say just let me know if you want to go down that path, or if you want to have another visit. We can chat about some of those in more detail after
Yeah,
you've had more
I
conversation.
think the next step, if we decide to go surgery, do we just use the portal and say, hey, we're ready for surgery?
Yeah, that's fine. If you send that in through the portal, then my nurse will pick it up, will identify it all, and then we'll just start
Yeah.
looking at date options for you and whatever
Okay,
else
makes
you need.
sense.
But
Okay.
how long the surgery recover? I think.
How long is the
Surgery
surgery
recovery?
itself?
Yeah.
Oh, the surgery recovery? Well, I guess it depends on how you define recovery. I mean, you're able to do normal activities pretty quickly right after the procedure, within days.
Okay.
You have the catheter for 5 days, that slows you down a little bit. And then you've got a period where you've got to recover some of your urine control, and that can take some weeks, sometimes even a few months till it's
Yeah.
fully back to where you want to be. But again, the actual surgery itself, your recovery is measured in days to a few weeks.
Okay. Yeah, you can go ahead.
Okay.
Yeah, thanks, Doc.
Yeah.
Thank you very much.
One last
Good.
question. Is the
Yeah.
genetics test going to be on the My Chart? I didn't see it. Should I send a message?
Let's see. So it's in it's interesting. It's in our media section. So there may be a way for me to just send it to you.
Oh, okay. Yeah.
Let me see what I can do about that. We should be able to. I should be able to do that, or maybe I can have my nurse do that. But yeah, it's we'll put it into the My Chart so you can get
Yeah,
access to
that'd
it.
be great.
The
Thank you.
reason is it's an outside study, so it gets sent to us like by a fax. So it gets loaded into
We'll
our
still use
system, but it
fax.
doesn't come
Yeah.
into the normal portal.
Okay.
But I'm sure there's a way I can send it to you as a My Chart.
Okay.
Okay.
Thank you so
Thank you,
much.
Doc.
All right.
Yep, sure thing. Have a good
Thank you very
one.
much. All right.
Have a good one.
Bye bye.